Good afternoon, everybody. Thank you so much for joining us on this Monday morning, afternoon, evening, depending on where you're joining from. We're just going to give a couple of minutes for our speaker for today to join us and for a few more people to be able to come into the room, and then we'll take it from there. Thank you very much. All right, thank you very much, everyone. So Dr. Austin Hopper has joined us. He's an assistant professor in the Department of Radiation Medicine and Applied Sciences at UC San Diego, an active member of the lung, head and neck, CNS, and genitourinary cancer teams. His research is focused on assessing imaging biomarkers of radiation injury, as well as genomic variants predictive of radiosensitivity, and this helps to inform planning techniques with the goal to minimize toxicity after radiation therapy. So Dr. Hopper is going to be talking with us today about lung cancer, talking us through some cases, real life problems, and we're trying to make it as interactive as possible to have a Q&A session. So please, put your questions in the chat. You can send it to me directly if you don't want to ask publicly, or you can just put it in the chat, and then I will read it out and have Dr. Hopper answer your question live. So thank you very much, Dr. Hopper, for speaking with us this afternoon, and you're welcome to begin now.
Sure, yeah, thanks for having me. Just making sure I'm coming through okay. I had to reconnect my camera here real quickly. And again, apologies for the mix-up. I thought I had missed the whole presentation.
Yeah, so that was my fault. I sent you the wrong email, but thank you so much for being flexible and for taking the time on a Monday to do this with us. We appreciate it.
Oh yeah, absolutely. No, it's my pleasure. I think, kind of like you mentioned, if there's anything specific you guys would like to go over, we can dive into that. I have a whole bunch of cases and a whole bunch of volumes we can look at rather than just kind of reviewing the general paradigm of lung cancer treatment. Um, I do have a little bit of my initial presentation before I took it home and tried to work on the rest of it. So I can start with some of that if that works for you guys.
Yes, that's fine. So we can do some of that, but we're really looking forward to the real cases and like showing the volumes and the delineation and all of that, talking through all of those as well. So we're happy to go through. Perhaps we can have like two halves of the meeting where we go through the initial presentation and then go into the real cases.
Sure. I mean, we can actually dive into like one of my more interesting cases from the last couple of weeks if you'd like. It'd kind of be maybe a little overdone if I just talk about, SPRT for early stage lung cancer and IMRT or 3D conformal for late stage. But let me pull this up here, a little bit more of an interesting one lately. Let me set this up.
Okay.
Okay. So you guys seen the right screen on this? Like full screen versus the presenter mode?
Yes. Yes, we
Okay.
can.
Let me get down to the case in question. So, one of the more interesting ones I had recently was 83-year-old man, presented with dyspnea on exertion, shortness of breath, cough, found to have an obstructing mass in the bronchus, as you can see here on his PET scan. Um, as can happen a lot with obstruction, with post-obstructive pneumonia, just inflammation in general. Over here on the right, you can see some mildly hypermetabolic lymph nodes. He was initially presumed to have local regionally advanced disease and recommended for chemoradiation. But those nodes actually hadn't been biopsied up front. He had one 4L node biopsied early on, and that was negative for carcinoma, as was the station 7 node. So we sent him back, and it turns out after about 5 different lymph nodes being biopsied throughout the mediastinum and bilateral hilar regions, there's no evidence of nodal disease. And so this is a relatively small primary, just about 2 centimeters. Most of my work with early stage disease is treating it with SPRT. either peripheral, close to central, but not basically completely luminal, obstructing a bronchus. It presents a little bit of a challenge for how do we effectively treat this with radiation, because given both his stage and various comorbidities, he was not a good candidate for chemo. Um, and treating to just 60 gray or 66 gray isn't going to be particularly effective. Um, so we brought him in for SIM just to kind of get a better idea of what was going on. He had had a previous debulking the first time he got the biopsies, and additional debulking when we sent him back for additional biopsies. So actually, that area of uptake you can see is almost completely occluding both segmental bronchi. Um, but when we brought him in, almost all of it was gone. So it becomes a little bit more of a challenge for both target delineation as well as assessing the full extent of disease along the bronchus. Um, so you can see here back prior to the debulking, it's much more clear exactly where everything was. And actually talking to his interventional pulmonologist, not only where you can see the more bulky disease, there was submucosal extension along the other side where it looks more like mucus plugging post-obstruction over here. So we kind of outlined the areas of concern and combined that with our 4D CT simulation, which I can dive into a little bit more later on how we do motion management here at UCSD. Um, but basically, there's a good amount of movement here. It's not really an ideal location. I mentioned I didn't want to treat to a relatively low dose for something without chemotherapy. So, you know, we look back to some of the data we luckily have from another one of our thoracic radiation oncologists, Jim Urbanek, who did a trial out at Wake Forest comparing SBRT to accelerated hypofractionation for more centrally located tumors and larger tumors that would usually not be good candidates for SBRT. And so the majority of patients on this treated with SBRT for the comparison group was to 54 gray and 3 fractions, while all of the accelerated hypofractionation patients got 70.2 and 26 fractions. And as you can see here, while it looks like the hypofractionated arm had a little bit more early local failures, over time that kind of washed out and was not significant, while the rest of our metrics that we look at for outcomes, both distant failure, survival, regional failure, were all similar between the arms. And I think what's also most interesting is this group, as you can see here, the hypofractionated arm had a whole lot more larger disease and much more central location than the SBRT group and still did fairly well with actually minimal toxicity. So this is a kind of treatment regimen we like to use in these situations here where there's not a great option either way with standard fractionation with SBRT. You're either compromising control or you're risking severe toxicity. So with this patient, taking into account what we learned from the interventional pulmonologist, previous imaging, we developed a nice set of target volumes for him. And looking at the plan initially, looks pretty decent here. We're meeting all of our metrics for heart, esophagus, lungs. Everything's well within the boundaries. And I really wish I had the original plan before I had dosimetry change it, because when you look at the heart, everything does look great, but knowing where that was, you can see on this patient, he had no history of heart disease, but he had significant amount of calcifications here, which while he probably hadn't seen a cardiologist or been diagnosed with any problems, he's at risk for lots of significant sequelae of coronary artery disease, which is visibly present on his imaging. So in these kind of cases, as well as young patients, patients otherwise healthy, anytime we can get away with it, basically, we like to add in a little bit extra constraints beyond that, which is just standard heart, mean dose, max dose, volume getting 50 with this fractionation varies a little bit. But so what I have here is the LAD and the circumflex contoured, and you can see our dosimetrists and physicists did a really good job of actually adjusting the dose to avoid these structures. And one of the reasons we started doing this is we noticed when we stuck with standard planning metric, I'm going to switch over to a whole other case here about a young patient, like mid-20s. It's not lung cancer, but it is thoracic. So he had recurrent thymoma, initially diagnosed with myasthenia gravis symptoms, resection, no adjuvant therapy, even though he did have some residual disease. developed a recurrence 3 years later, which was eventually treated with radiation, where you can see the plan here, to 66 gray and 33 fractions. When he actually came out to see us, he had another recurrence, um, fairly large, as you can see, but given his young age and previous history of radiation, we even sent him over for treatment with proton therapy, trying to, reduce heart dose as much as we possibly could. He got almost the entire treatment here at UCSD, but unfortunately, proton machines are a little finicky. There is downtime from time to time. And when it goes over a couple fractions, we send them out to some of the other centers in the country. And so he went off to another center for the last few fractions of his treatment. So what we can see is for the first 55 of 60 gray on this plan, it looks like this is a great mean heart dose, which is really nice. That close to the heart, it's impressive. But unfortunately, 3 years after therapy, despite an excellent response to treatment, he developed dyspnea on exertion, palpitations, chest pain. Workup showed that he had normal left ventricle function, but a CTA showed significant stenosis in his coronary arteries. And on a cath showed 90% stenosis in multiple areas of the LAD and also significant areas of stenosis in the circumflex. So looking back on that plan that we thought was great. Oh, I'll skip some of this right now, but what we found was when we actually look at the specific volumes of those arteries, you can see that while the target area of the proton treatment plan was avoiding them, there's some dose fill within there. This is kind of a reconstructed PTV since we don't use standard PTVs with protons, but just area that was getting full dose. And you can see here, while the mean heart dose was very, very low, these areas of the coronary arteries were getting an actual significant amount of dose. And so bringing us back to lung cancer treatment, people have discovered from lots of looking back at these people who had these side effects after treatment, even with good mean heart doses, is that the actual dose to the left anterior descending getting 15 gray is very strongly correlated with not just the stenosis we saw in that patient, but also basically any type of cardiac event. And while that risk is still present in those who have heart disease, at baseline is most significant in those that don't. So while our initial patient, we can kind of guess that he had some level of heart disease based on those calcifications, the second one would have been a big candidate for this type of sparing if that had been available at this time. And another follow-up study of that previous one I just showed is comparing the LAD dose to the mean heart dose, which is our standard metric, is that even when we can get a low mean heart dose, if that LAD dose is still above that 15 gray threshold to 10% of the volume, they're at a significant risk for these types of side effects. And so if you pay attention to that, it's one of those things that we can include in radiation planning, where over here you see just kind of a standard plan, avoiding the normal metrics, has a nice mean heart dose for how close it is to the mediastinum and heart. But just that little bit of spill is catching the LAD, and that volume is way higher than we would like to see, knowing what we know now. And so just by adjusting how we're weighting these beams through an arc, we can bring that significantly down and not ruin the rest of our metrics. So taking that kind of knowledge into the patient we were considering, this was the replan dose here. But again, if I had the original one, it was up, this line for the LAD was way over what we were. I think it was about 40% was getting 15 gray. But just adjusting a tiny bit, we can get that significantly under and spare potential side effects in these patients. And looking back at what that actually cost us for the rest of our metrics that we care about, it was very little at all, almost no change in the lung, a tiny increase in the mean heart dose, but still well below our thresholds, and a tiny change in the esophagus here. So it went from just 18 to 19. So it's just little tweaks you can do in a strange case like this, where you're already a little hesitant about causing toxicity in the bronchus and the vasculature, but you also still have to pay attention to what's around it. So that's the one remainder I have from the initial presentation. Would you guys be more interested in, say, like SBRT type treatments, early stage, or more local regionally advanced palliative, things like that?
So let me just say that for our population, we do tend to see larger tumors, certainly locally advanced and sometimes metastatic cases. And the other thing about it is that SBRT, thoracic SBRT, for example, is not practiced in many sites. I think that, something that might be of interest to the audience will be talking about hyperfractionation. I think that's more feasible for more of the sites that will be represented here. And then also even just looking at the contour. So for example, talking about the circumflex and the LAD, showing how, those are done. And then the things to think of. So I wrote down a couple of things.
Yeah.
So what are the factors that you need to keep in mind when you're planning? What are things you need to be conscious of in delineating, in planning, and in plan evaluation? Size limits of tumors to radiate, side effects minimization and management, which you've talked about, to be honest. Motion management, which I think is important. What did I write here now? I wrote something here. I can't read it. So that sort of thing. I mean, we certainly don't have access to protons. We're not doing a lot of SBRT. We're doing conventional and then some hyperfractionation. So, what I think will be important is with the tools that we have, if you do have hyperfractionated, what are the doses you should be looking at? How do you plan it, and things like that.
Yeah, absolutely. Let's see. So that regimen that I just discussed, the 70.2 and 26, I
Yes.
think really that's kind of my go-to for anything that's like endobronchial. There's a lot of literature out about various regimens such as like 60 gray and 15 fractions. I think that's very convenient for a lot of patients. But unfortunately, what that tends to do is you're compromising a little bit of the BED for control, and you're actually ending up with a higher EQD2 looking at like a 3 gray like you would for a normal structure. So I always keep that fractionation in mind, and I actually almost never use it because it's almost the worst trade-off if you have a patient that can come but for 5 weeks daily, basically. Um, what I tend to do more, let me pull up a case and I can show you guys the volumes. I did have a patient where she was kind of similar age, almost worse functional status. And 5 weeks was just not reasonable for her. But she had a relatively large tumor. Let me see. So what I did in this case is I was like, how can I get 15 fractions to get a little bit higher of a BED, but still also cover the area I need to and not compromise normal structure. It's not endobronchial, but it is kind of a strange case in the sense that it's basically wrapping up and down the chest wall. So another case where I would not do SBRT. Let me throw back on the share here. Okay. Can you guys see this one?
Yes.
Okay.
Thank
Sorry, I have two screens and I'm always horrible at sharing the right screen. Um, so let's look at, so she has this large area of collapse in front of where this actually very thin tumor was, but extending like 6 to 7 centimeters. And again, this is a patient where no nodal disease despite multiple biopsies. There's lots of areas of uptake that, could be concerning, but were thoroughly evaluated, biopsied, things like that. Um, and again, poor functional status. So even a regimen over 5 weeks, trying to get the dose up a little bit to try to get to a more definitive radiation only BED, where you want to be closer to 100, wasn't really viable. And even, again, this is kind of too big, too up against the chest wall for me to consider SBRT or anything like that. But to get to where we needed to go, I knew with all this kind of, sorry, I'm showing you the PET and it's not that pretty. Let me get back to actually looking at what's going on. So the PET really helped kind of define what was tumor versus what was collapse here. And you can see she's up against the pleura with all this disease, but I don't see any kind of clear evidence of invasion. Um, so I wanted to cover along it, not too deep into it, not make chest wall pain a limiting factor for her treatment. In general, most patients that get that tends to be generally mild, But when you're hypofractionating, increasing the dose per fraction, but expecting them to stay on treatment for 3 weeks rather than, 3 to 5 days, you don't want something that's going to cause them to quit and make the whole thing kind of pointless because they didn't get an effective dose, but we did give radiation to the area. We did cause potential side effects. Um, so there's a relatively more well-established 10 fraction plan going 50 gray and 10 fractions, which is kind of SBRT-like in the sense that you're getting more dose per fraction, and there's not really as many size limits as with SBRT. So what I did is that larger area going beyond the tumor, kind of extending like a CTV along the chest wall. I took to 55.5 in 15, which ends up being pretty equivalent for disease control. But then I boosted the actual tumor itself to 63. Uh, so that will get you up to a much higher dose, closer to that 70.2 and 26, but also having a lot less potential side effects along the chest wall, a lot less risk of pain, risk of rib fracture, and things like that than trying to do a lot of dose in 5 fractions or less, something like that. Um, but again, I think all of these are just adjustments you can make based on where the disease is. This isn't something I would want to do similar to that other case when it's in bronchial, because really the threshold that they've seen from a lot of studies, well, I can pull up something in a little bit, but for looking at risk of bleeding, necrosis in the airway, things like that, the threshold for that is getting close to 100 EQT2, looking at an alpha beta 3. So it's kind of a trade-off between what you can get in for disease control and what you're risking for toxicity. When you're up against the chest wall, it's more about just making it somewhat tolerable for the patient because the chest wall pain is real as, you start to increase your dose per fraction beyond, a standard 2 gray per fraction. Let me see. As far as more local regionally advanced, unfortunately, I've had a whole lot of those lately. Um, I think one thing I run into a lot is the problem with a patient who has an obstructing mass causing a big pleural effusion, because that's going to change what you're targeting all the time. And when they also have lymph nodes, you can't just adjust to the primary tumor because that's going to throw everything off. It's going to push dose anterior into the heart or into the anterior lung fields. Um, so while a split course was oftentimes thought of as just a palliative treatment, um, I've done a couple of these lately where I have a patient who, well, first, let's start with the target volume delineation for this patient. So this was a guy presented kind of similar to the other one with dyspnea, chest pain, things like that. You can see big, large mass here, concerning for something posterior, but also it's very obstructed. So that could just be the pneumonia going on. He had a very elevated white count. Lots of either mildly hypermetabolic or it's got some kind of just on the threshold of what would be too high for metastatic here coming up above the cricoid. So for him, we know he has significant disease. We know he's got a little bit of an effusion back here already. What really helped in this case is the contrast for his SIM, which gave us actually really good delineation. A lot of times when a patient's really symptomatic, I'm kind of tempted to bring them in for SIM as quick as possible. If I have a PET, I'm like, oh, I can use that for target delineation. Contrast might not be as important. But the big benefit that it gives us when someone has a lot of collapse and you have a pretty good scan with contrast, you can see where tumor is versus everything behind it by vasculature and blood vessels. And his tumor is actually, as you can see, wrapping around this vasculature, but it helps you isolate where the actual disease is. So that area of uptake on the PET scan way back here, I'm not worried about it. And this was another case where we tried to, he has a lot better SIM than a lot of patients. You can see the coronary vasculature a little bit better here. And really the one that is the most strongly associated with those cardiac events is the LAD, but the circumflex is also, as is point max to the left ventricle. But for this patient, like I was talking about, unfortunately, that effusion started to grow during treatment. And when I was treating those superior lymph nodes, that one that was just approaching like the IMN region, um, everything shifted. So let's see. You can see them at the start of treatment here. Oh, did my share stop?
Yes, you stop sharing.
Oh, okay. Okay. So looking at his daily imaging now. Um, so the start of treatment, a little bit of shift required, but nothing too significant. Unfortunately, as time went on, you see that effusion got a lot larger. So we can adjust to the tumor, and it even looks like he's having a response now. But when we're trying to treat the lymph nodes, it's unfortunately going to be missing. It's going to be shifting as he's up here. So we wanted that to be down here. By shifting for the primary, it gets offset, and it gets even worse up with these cervical lymph nodes. Um, But in a case where you see a patient having a good response early, he's on chemotherapy, he's tolerating it well. What we did was talk to his medical oncologist to be like, okay, we're just gonna basically add an extra cycle of chemo in here, give him a break during the radiation. So we took him to 30 gray and 15 fractions. And then we did a reset. And so what we can see over here is a significant response here. So a whole lot less disease than what he had previously. And while that effusion is still there, it's been stable over these last 2 weeks. And I actually didn't want them to tap it this time unless he was super symptomatic because we resumed treatment on him. And this isn't moving anymore. And not only is it not moving, it's a much smaller target than it was previously. And so that's a lot less dose pushed into these peripheral lung areas than it was prior. So it lets us basically keep accurate to our target, reduce overall total dose to lung over the course of treatment. And this would have otherwise had to been switched to just, hey, we're going to stop. This was a palliative plan, but we're still trying to take this guy to a definitive and hopefully curative dose. But it just requires an adjustment in what you're doing and working with the medical oncologist to make sure, hey, we're not going to stop everything. We're just taking a short break for like a week and a half for him, allow him to continue to respond, hopefully open up a little more. And in his case, like we can see here, it's a great response to this therapy. So in some of these local regionally advanced cases, I think a split course isn't just a palliative option. I think it can be an effective option for keeping someone on treatment and getting them where they need to go.
So I wanted to ask, can you talk a little bit about motion management?
Yeah, I can. Let me grab another thing I have here. Um, so while I pull this up, we use two different types of motion management here at UCSD. Our primary site in La Jolla is frequently done with just gating off the motion we see on a 4D CT, while our site up in Encinitas likes to use abdominal compression. Um, let me grab a nice little summary of the different options here. Okay. So, like we talked about, lung moves with breathing, lung moves with effusion sometimes, unfortunately, too. But the real problem is not only does it move, it also can make your target delineation more inaccurate because you're having a CT trying to take a picture just in time. But we often use these free breathing CT scans for radiation planning. And that's why they, in general, look a lot more horrible than a diagnostic one where they have them do a breath hold technique. But the unfortunate fact is a lot of the patients that we have with any malignancy, but particularly lung cancer, is they have a lot of difficulty with a breath hold. They have shortness of breath, they have a cough, they have things like that. So there's going to be motion, and we need to account for it not only to accurately see what we're aiming at, but to accurately treat it on a day-to-day type of basis. So these pictures down here, you can see kind of the reconstruction of a free breathing CT scan where there's lots of artifact introduced by a lot of movement in there, while gating can actually reconstruct it in a different way, basically, where you're seeing the different phases of the breathing cycle separate. And so, oh, this is an old resident one here, but basically I'll kind of jump around like they are here. So margins when we don't have accounting for motion management are going to be a lot larger. And it's just kind of a necessity. If you have no way to manage the motion, you're going to absolutely have a lot more sup inf margin, but you also need more lateral margin in some cases too, depending on where this, you know, target is. So not only is this motion management a way to accurately aim at it, it's a way to reduce that dose to the healthy lung. Um, so there's a lot of different varieties of this. As I mentioned, we usually use gating and abdominal compression. I know another facility in town uses basically the active breathing control where they have like a monitor in their mouth and kind of like a nice little goggle system to tell them exactly what's going on and when to do what. That seems kind of complicated for a lot of cases, and abdominal compression can be a little uncomfortable for patients sometimes as well. Um, but there's pluses and minuses to both types. DIBH is a really good option sometimes for those tumors that are really down low, close to the diaphragm, if the patient can tolerate it. Again, one of the big problems is it doesn't work great with people who have lung cancers and are symptomatic. But in cases where they can do that, they have, a good pulmonary reserve, they can hold their breath for a decent amount of time, it's really ideal because that's keeping it more still than anything. Otherwise, we're just accounting for motion and only treating in specific phases of breathing. If you can get away with DIBH, it's good. But again, unfortunately, we just don't have the opportunity to use it a lot for treating lung cancers. Um, so one thing, those 4D CT sims, they do take longer, requires physicists to be there in general. So it's a bigger chunk of your time, especially when your sim is competing for volume with every other case that's coming through the department. Our kind of setup is usually we have wingboard, we have a vac lock, we have a little sensor we'll get into, which is how we actually track the motion of them as they're breathing and when to actually have that specific phase of breathing correlated with what we're seeing on the CT scan. This is just a summary of how to locate that thing per patient. And so in summary, we're basically getting multiple images at different capture positions through the ring of the CT and correlating it with the motion on that sensor we're tracking. A lot of pictures, like I said, it takes longer, but then, we have a good basically reconstruction to where we see what we are planning on treating, how much motion there actually is. We can decide how we want to treat them. And what I mean by that is what we would say over here is, are we treating them, gate 100 or gate 3070, which is which different phase of the breathing cycle is the beam going to be on, and which of these phases from that 4D CT are we actually drawing out the tumor on. So when there's not that much motion, we can do it on all the way, from 0 to 50. That's basically the full breathing cycle. Well, when there's more motion, we want to restrict what we're doing. So we use this little 30-70 window. Um, and those are cases oftentimes where it's beneficial to have fiducials, which can be really helpful for a small target that you might have difficulty seeing on a daily setup. But if you're treating a large lesion, oftentimes it's a lot easier to see. And so, again, we talked about how they can have difficulty with breathing. They can have difficulty with maintaining a stable breathing cycle. It's something that you also have to keep an eye on. There's always, myself or one of the other treating physicians and the physicist and the whole RT team there monitoring that during the treatment. And let's see. This is kind of a description of the different phases we end up on. Pretty much everything I was showing you guys on the previous contour, we are basically putting our volumes in, our target delineation on the average. But what we're actually looking at is the few CTs to oftentimes either, the 0 or the 50 or the 30 and the 50 and the 70, depending on what type of gating we're doing, to actually draw out how much that target is moving. And then we're also either using the min or the MIP, depending on if we're treating at gate 100 or gate 30-70. The free breathing is particularly useful for those patients with large tumors, lots of issues, because these other ones are reconstructions. They might be able to show the position accurately, but they're not going to show some of those basically like vasculature, lymph nodes, things like that. They can't be delineated quite as well. So I always go back and forth to the free breathing if I see something that's a little bit hard to identify, because that's often the one that's also going to have the better contrast enhanced scan or portion of the scan, I should say, based on when it's captured versus when we're grabbing all the other images slowly over time, monitoring breathing. So I think it's a longer scan. I like the gating in the sense that I know exactly what's going on while things are happening. I think this one doesn't have too much on abdominal compression, but one of the big issues with abdominal compression is while it can help a lot with that superior and inferior motion. Here, let me see if I have that nice abdominal compression graph still. Anyway, but the summary of that is abdominal compression can also introduce more lateral motion. So you're restricting the sup imp motion, but you can get more side to side. There's variability based on patient positioning. Both, you make sure that the compression is just the same every time, as well as the problem is you're pushing everything down, right? You're pushing stuff up, basically pushing the diaphragm up, but if they have a difference in abdominal contents, that can change actually how much that excursion is. So while you're checking with imaging daily to make sure everything lines up, the variability in that forced shallow breathing you've introduced, it can vary day to day. So whether that's you're going to miss target or you have to make your margins larger to account for it, it's tough to say before you do your first fraction. But once you start, you don't want to delay them too much. You can't really, take time for a replan in a lot of these cases. So there's pluses and minuses to both kinds. As I showed in that one slide, there's a whole lot of different options. I'm familiar with maybe 2.5 on the ABC type where I've seen people treated on it, but I don't treat anyone myself. I think it's still a work in progress, but I think it really helps with target volumes. Like if I tried to treat some of these smaller tumors that are kind of lower in the lungs, when I see how much they move on a 4D ECT, if we weren't accounting for it, it just requires a lot more lung to be treated. Does that kind of answer the question?
Yeah, so I think that the next question I was going to ask, and this ties in with what I think is in the chat, is that if only a free breathing scan can be done, which is a typical case for a number of institutions in Africa, any strategies on how to determine margins without overestimating expansions, which could increase the risk of pneumonitis and other unwanted toxicities. So again, just to give a little context, first of all, many centers will not have 4D CT. Very few centers will. As a matter of fact, very few centers will have 4D CT. And very few centers will have respiratory gating and things like that. So I think the abdominal compression will probably be the closest we'll come to motion management or breath hold for patients who have the lung function to be able to do breath hold. So in those situations, what advice do you have to make sure that you're not increasing patient toxicity? And Melinda, I see your hand. So in those, what advice you have to make sure we're not increasing toxicity? And I'm going to ask a question about SBRT later, but let me just hold that question for now, and then I'll allow Melinda to unmute yourself. And are you able to unmute yourself?
Oh, yes, I can. Thank you so much.
Yes.
So maybe I would really appreciate maybe your insight based on your experience. So, motion management is one of those strategies which is very difficult to implement, particularly in low, middle income countries, just due to, difficulties in having that technique available. So something that I have come across, which I'll be glad to just hear from your experience is, if I don't know if you're able to share your screen on one of your presentations that had a slide on motion management with a coronal simulation image that really showed those, changes or streaks like that we see when we have motion.
Mhm. Yeah, let me bring it up.
Excellent. I think that would be great if I could use that as guidance. Exactly this one. So on this, on the free breathing scan, so one strategy that I have come across, and I'll be glad to hear from your end, is if you measure like the distance from where you start having those horizontal, gaps, where you're seeing the motion to the
Mhm.
diaphragm, like right to
Yeah,
the end of
right.
that vertebral body. Exactly. I don't know if you have a cursor. Oh gosh, I think it's hard if I can't even.
Well, I don't see an option for a draw thing.
Yeah, okay. So
But yeah,
measuring the distance, yeah, so measuring the distance from that horizontal graduations with the gap to right at the end where you start seeing that T vertebral body, that
mhm.
distance can be used, to determine the actual motion for a particular patient if you do not have a free breathing scan. So it helps to personalize in terms of the margin for a specific patient based on that margin you're seeing on a free breathing scan. I don't know if there's any evidence for that in terms of literature, but it's one of those techniques that I have been taught by, some seniors. And I'll be glad to just hear from your comment in terms of if you have come across it from your
Yeah, and
experience.
actually, let me try to find it here. There
Hmm.
actually is a literature thing almost on that where they monitor all the spots, and you can kind of see it on this where those gaps are bigger and they're smaller up here, which is
Hmm.
what we know from when we get a like a 4D CT. If I'm treating
Hmm.
something high, I know it's not going to be moving as much as something down low towards the diaphragm.
Yeah,
Uh,
especially the lower lobe, cancers, like, the motion is
oh
just
yeah, let me
compared to the
see.
upper lobes.
I had
Just
to
to add to
really.
that, while you're pulling that up, is something else that I've seen somewhere, or that maybe was taught to me a few years ago, was to do two scans, one with maximum inspiration, one with maximum expiration, and then just try to find like an ITV between those two volumes on those two scans. If you're not able to do, so just
No,
to add to that, see,
I think that would be a
that
great
makes
method.
sense.
Like that'll show you the max of what you're going to get. And if you have them not, taking the biggest breath they can, you don't necessarily need to go to the highest point of that. But I think that's a very good option. I think, it's definitely very tough. I think when I talk about making bigger margins, really what it is if we were thinking of like SBRT instead of like a 5 centimeter expansion, it ends up being like 1 centimeter soup inf. So it's not huge, but when you're talking about a larger tumor, then it ends up, being a lot more lung volume. So
Um, and so I was going to ask a question about SBRT that was sent to me here to say, what is the core? Let me just see that now. What is the core minimum requirements that you think that a center should have as they begin to think about, as they begin to prepare to be able to do SBRT?
well,
I know that's an entire session, but just
yeah, I can actually even like put together some of like our old cases, initial ones where even without like doing arc therapy, we did a lot of static beam SBRT for lung tumors. Um, I think a big thing is just making sure you have a physics and dosimetry team that, is cognizant of the planning requirements and pitfalls. I think it's easy to basically your OARs need to be drawn well. Even here where we have like multiple people looking at them, if the things you're right next to aren't perfectly accurate, it's a lot of dose in that PTV that could be potentially harmful if you're not sure where you're going. I think for peripheral lung SBRT, it's pretty well established that even early on when it was starting, there wasn't a lot of advanced motion management techniques. They were just, like we talked about, having a little bit more margin for a presumably small tumor. I think a lot of the stuff that I talked about, like 4D-CT specific gating, things like that, that gets important when you start getting towards the central areas, which is about 2 centimeters from the bronchial tree. I think I have a nice picture of that somewhere too. But anyway, that's where the risk really cranks up, right?
You have to show us these pictures. You keep talking about you keep talking about these pictures, but you have to show them to us.
Yes, I wish I had my full presentation, right? So let me, so this is an example of like, our proximal bronchial tree contoured on one of our plans for a patient. And then I threw this 2 centimeter margin on here. So anything abutting this starts to be what we consider central. That's where the risk, if you're getting dosed to these areas, goes up for potentially fatal bleeding, airway necrosis, things like that. Even as you come over here, there's a lot of cases on those trials where they did dose escalation of esophageal ulceration necrosis into blood vessels, which were fatal as well. So that's where, you really want to think about very detailed motion management, dedicated daily imaging with fluoroscopy, things like that. As far as you're getting more peripheral, you're in a much safer area where your risk becomes more like this can be pneumonitis, which can happen with treatment anywhere you're doing SBRT, or a little bit of chest wall pain and an increased risk of rib fracture in the future. So for those ones, I think, you mentioned abdominal compression, anything like that, just to minimize the motion. So you minimize that expansion that you have to do just to account for it is a really good option. And then it's just the treatment planning from that point on. I think being a little more specific with visualization and motion management are the ones that are going to be really necessary for the central and ultracentral, where you have like disease actually abutting these airways. But that also ends up being a change in fractionation as well, oftentimes.
All right, thank you so much. So we're getting close to the end of the hour. We have 8 more minutes for any questions or comments from anyone in the audience. If you have any questions, please send them to me or type them in the chat or raise your hand, and I'll have you unmute and ask your question live. Otherwise, perhaps Dr. Hopper will share his slides with us. And then we can send them out to those who've registered for the meeting, and then we can ask any questions via email afterwards. So, just to say that thoracic radiotherapy is it's a very new, it's like an emerging specialty in Africa and in LMIC. And I know that it's going to be difficult to keep up with some of the things that we're hearing, but my theory is that the more you listen, the clearer it becomes. So hopefully we will have more sessions, more opportunities to interact with experts and people who are practicing it every day. Just to say this, that for anyone who feels like, oh, this is very, high up there, please don't be discouraged. We'll keep doing this and it'll keep getting clearer. Hopefully we'll have some kind of hands-on session where we'll go through everything from the beginning, contouring from organs at risk to target volumes, plan evaluation, planning, and all of that. And in the meantime, we'll just keep learning and trying to get better. The lung cancer radiotherapy thoracic radiotherapy is underutilized in Africa. And I think that there's a lot of value that we're missing by not utilizing it adequately for patients with lung cancer on the continent. And I think it's important for us to begin to work to change that. So, we'll continue doing this series and we'll continue engaging with experts all over the world to help us develop our strengths. So I don't see any hands or any questions. Dr. Hopper, thank you so much for today. Thank you for being flexible. There was a miscommunication, and thank you for being able to hop on the call and talk with us. We hope to have you again sometime in the future and have more time to be able to go through everything with you from the beginning to the end. Thank you to everyone who's taking time to attend. See you at the next session.